a private project, no affiliation, a model to spark discussion on sustainable healthcare. A single gene therapy can end a rare disease for life, rewriting the faulty biology in one treatment. But it can cost millions, paid before anyone knows the fix will last. That gamble stalls innovation and keeps these cures from patients. Here's the twist. Standard care looks cheap a little each year, but paid for life. The one-time therapy costs more now than nothing. The area under each line is the total spent. After about 7 years, the cure has already cost less. Over a lifetime, far less. Meet the players, each with one goal. The maker, the neutral institute that sets the rules and holds the money, the patients, the payer, and the others who share the risk. Today, the payer hands the manufacturer the entire price up front, millions, in a single payment. The therapy is delivered, but the money already changed hands before anyone knows whether it truly works. Chapter 2. The manufacturer runs its clinical trials, then files the evidence with one neutral evaluator. They negotiate the price and pin down exactly what success will mean. Those targets become the trigger for payment. And success is never left vague, it is written down as measurable targets before any money moves. Longer overall survival, a better and lasting quality of life, a durable response with no relapse, fewer hospitalizations, function restored, movement, vision, an organ working again, or a disease biomarker brought back to normal and held there. Whichever targets are agreed become the exact trigger that releases the escrow. Now the split. Only a small unconditional slice, about 15%, is paid to the manufacturer now. The large remainder, around 85%, is locked into escrow, released only if the therapy earns it. The therapy reaches the patient. And for years, each patient's response is measured against the agreed targets and reported back to the institute. While the verdict is still years away, the escrow need not sit idle. It can be put to work in 3 different ways. Here they are together, we'll follow each in turn. Route 1. Invest. The escrow is placed in a broad index for the whole waiting window. Over about 10 years it compounds, 85 grows to roughly 110, and that growth stays with the fund to follow the outcome. Route 2. Fund care. Instead of investing, the escrow pays for care the insurer must cover anyway, easing today's budget, in exchange for better terms for the maker at the outcome. Route 3. A gradual drip. For a small or medium manufacturer that cannot wait a decade, the pool releases slowly once partial success is verified, keeping a cash-poor innovator alive through the long wait. When the observation window closes, the measured result decides how the escrow resolves. There are 3 possible endings, and the same held pool resolves very differently in each. We'll take the invested pool as our example, and walk all 3. The first ending, success. The targets are met, and the whole grown fund is released to the manufacturer. It was paid because it worked. The second ending, a partial miss. The maker quietly arranges the patient's standard of care with rival firms, at competed down prices, and the fund is then split 3 ways, to those care providers, a partial recoup to the maker, and the remainder back to the insurer. Nothing is wasted. The third ending, failure. The manufacturer receives nothing, the entire fund returns to the insurer, so the public loss stays bounded. Step back, and it is one idea, a single pool of held money that keeps working and pays out only for value truly delivered. Finally, a backstop. Across the whole book, the insurance system pays a premium to reinsurers, who absorb the rare tail where many therapies succeed at once, a shock no single payer could take. And here is the whole idea as one control system. Each rule bends a single player's self-interest toward the same goal, value paid for, risk bounded, care delivered. Pulled together, Every incentive points at the good outcome. In sum, every part earns its place. Weak evidence, budget shock, idle money, dying innovators, wasted failure, and correlated risk each maps to one specific fix in the design. Set beside today's default, the shape is clear. The payer's day one cost and its loss on failure are both bounded, held money stays productive, and payment follows real, measured value. So why build this? After 2 years inside market access, one conviction took shape: align every interest instead of policing it. Reward genuine success, share the risk rather than dumping it on one party, and never let capital sit idle, pulling cost down by rewarding good work, because a treatment that works once can cost less than a lifetime of the alternative. And so we close. This idea is Leon Illin's turning an incentive problem into an incentive solution, a self-regulating way to pay for therapies that works to the benefit of patients and of the people who create their treatments. Thank you for your attention and your time. He would truly appreciate your feedback.
I definitely would, and as the creator of this idea, I would like to just summarize this personally and thank you for listening till the end of this video. It was very long. I hope it is understandable. So, in the end, it's just connecting the dots and the lines of incentives